Congenital adrenal hyperplasia, or CAH, is a group of inherited enzyme defects in adrenal steroid synthesis, leading to glucocorticoid deficiency, with variable mineralocorticoid and androgen excess. The most common cause is CYP21A221 hydroxylase deficiency, accounting for 90 to 95% of cases, followed by defects in CYP11B1, CYP17A1, HSD3B2, and POR. All forms lead to cortisol deficiency, which removes negative feedback on ACTH, resulting in chronic adrenal stimulation and hyperplasia. Depending on the enzymatic block, mineralocorticoid deficiency may cause salt wasting, while androgen excess develops due to shunting of precursors towards sex steroid pathways. In females, excess androgens cause virilization of external genitalia in 46 XX disorders of sex development, along with hirsutism and oligomenorrhea later in life. In males, classic CAH may present with adrenal crisis in neonates, and later with precocious pseudopuberty and testicular adrenal rest tumors affecting fertility. Clinical phenotypes include classic salt-wasting disease, simple virilizing form, and non-classic late-onset androgen excess presenting in adolescence or adulthood. Classic salt-wasting CAH presents in neonates with dehydration, hypotension, hyponatremia, hyperkalemia, and life-threatening adrenal crisis. Simple virilizing CAH presents in early childhood with progressive virilization and signs of precocious pseudopuberty without severe salt loss. Non-classic CAH is milder and often presents in adolescence or adulthood with hirsutism, acne, and menstrual irregularities. Diagnosis relies on steroid profiling, especially elevated 17-hydroxyprogesterone in 21-hydroxylase deficiency, with mass spectrometry preferred. Other markers include 11-deoxycortisol in 11-beta-hydroxylase deficiency and elevated 11-deoxycorticosterone in mineralocorticoid excess states. Imaging with adrenal CT or MRI shows hyperplasia or nodules, and testicular MRI may detect testicular adrenal rest tumors in affected males. Treatment centers on glucocorticoid replacement, typically hydrocortisone 10 to 13 milligrams per square meter per day in children, divided into multiple doses. Adults are treated with hydrocortisone or prednisone at the lowest effective dose to suppress excess androgen production while avoiding overtreatment. Mineralocorticoid deficiency is treated with fludrocortisone and salt supplementation in children, guided by plasma renin activity. Stress dosing is critical, requiring 2 to 3 times the usual glucocorticoid dose during illness, surgery, or trauma to prevent adrenal crisis. Monitoring includes serum androstenedione, testosterone, and 17-hydroxyprogesterone to avoid both undertreatment and overtreatment complications. Long-term complications of overtreatment include growth suppression, osteoporosis, metabolic syndrome, and adrenal suppression. The key clinical takeaway is early recognition, lifelong hormone replacement, prevention of adrenal crisis, and individualized dosing to optimize growth and fertility.